So how timeline is important? What is thrombolytic therapy? What is STEMI? So what are the goals? The goal is reduction of infarct size. How? Reperfusion. How early? The best time is every minute means muscle. But how to decide cutoff? Dose to balloon minus dose to injection time 120 minutes. If you want to remember, one figure is 120 minutes. So there are two ways we all know PAMI is better. So primary PCI obviously better than thrombolytic therapy, but it has some feasibility problems. So those who can afford PCI, better thing is to do primary PCI, otherwise just thrombolyze. And if after thrombolytic therapy, successful therapy within 24 hours, 3 to 24 hours, they should undergo angiography. If required, plastic can be done. That is pharmacoinvasive. Next topic is the pharmacoinvasive therapy. But if failed, that is my topic is, then it should be at the earliest because time is muscle. Minute means muscle. You can see here very well, the best time is initial that we initially used to say golden hour. Now we say it is the highest ischemic term allowed is 120 minutes. You can say the myocardium which can be salvaged is rapidly reduces as the time goes on, and even after 4 to 6 hours, there is significant loss has been occurred. Though still has been seen even after 48 hours, certain cases, but these are anecdotes and there are certain limitations, minimum benefit only. So time is very, very important things. So that is how it came to know. This is the PCI related delay. If dose to balloon minus dose to injection time is more than 120 minutes, you can see here very well. You can very well here see. So then thrombolytic therapy is the preferred treatment. And you can see even both it is thrombolytic therapy or PCI, if 30 minutes become 90 minutes, mortality becomes 7% to 16%, more than double. And PCI from 30 minutes to more than 200 minutes, then it becomes from 3% to 10%. So it is, hard point is very, very important. Again I said, PAMI is better, we all know, but the ground reality is different, whether it is a delay from ambulance, a delay in awareness, delay in discussing with the relatives, all uncles and aunts, and discussing with the primary physician, ambulance services, traffic, so many issues are here. Even in US, only 20% of the hospital have cath lab facility, and India, per cath lab, we serve 1 million population. So that is a very, very less availability. So what are the facts? 3 million STEMI per year. Only 58% get thrombolized. Out of these patients, patency means some flow is there in the 70%, TIMI3 flow 60%, and tissue perfusion, that is the ideal way, is even less than 40%. And even those who get 10% reocclusion in hospital and 30% within 3 months. Though a spontaneous recondyligation is there, but it is after 12 hours, so it is not of much use. Even if you say the hard data, TIMI3 flow, the mortality is 4%, TIMI2 7%, TIMI1 9%, and that is no tissue perfusion, that is a myocardial perfusion failure, then mortality is 16 to 20%. So it is. So what are the patients who have common chances of failed thrombolysis? The commonest reason is delayed presentation and elderly, smokers, alcoholics, anti-VLMI, and complex lesions type BC. How to recognize it? Though there are echo, angiography, MRI, there are so many things. We have TIMI count, TIMI frame, TIMI blush, all these things. But most common is clinical and ECG. ECG is simple. There are again different definitions, 60 minutes, 90 minutes, 120 minutes. But most common accepted is 60 to 9 minutes, less than 50% resolution of ST elevation. Clinically, again, the disappearance of pain does not mean there is a successful thrombolytic therapy, because various pain threshold, elderly, diabetic, analgesic, and other way around. Patient may be successful thrombolytic, but there may be pain because of pericarditis. Other things like hemodynamic or electrical instability are the very, very important clinical parameters. So once we decided that it is failed thrombolysis, what next? First thing is confirm it is STEMI. It is not a STEMI mimic, because patient has pericarditis, you thrombolize, pain is same, ST elevation is same, and then you take patient for urgent plastic angiography. No. So here, What are the options? Conservative, repeat thrombolytic therapy, rescue PCI. And various trial has been done, and you can see the event rate in the rescue PCI was 15%. What event rate means? Mortality, repeat revascularization, severe heart failure. Mortality reduction was there definitely, but not very high. Most important, the benefit was because of the severe heart failure and reduced repeat revascularization, but at the cost of increased mild minimal bleeding. But high bleeding risk was there, but only very less. Some stroke was increased. So you can see the data, this, just to name few, TAMI, Rescue, and Vermeer. Then came the Merlin, again the 50% patient only had a stent, but this is the 2005, that we, the REACT trial, again 400 odd patients, what it showed. Yeah, you can see here, different data like mortality, 2%, 8%, 18%. But this one important thing is shown, even repeat thrombolytic therapy is even worse than conservative therapy. So what ACC and ESC says, class 1 indication for failed thrombolytic therapy, time is very important, urgent. This is the patient which I saw last week, entry-wall MI at Bombay Hospital, Mumbai, chest pain, I thrombolized, failed thrombolysis. After 3-hour ECG, next down, almost same. Patient took 24 hours to apply for the Mediclaim, another 25 hours to get the permission. After 48 hours, this is the angiography, totally occluded LAD with collateral. Are we talking about the thrombus? So when to do angioplasty? If patient is asymptomatic, he is not in a shock, not severe heart failure, no electrical abnormality, the only thing which can suggest intervention here is the, what it is the viability. So to summarize, failed thrombolytic therapy is a common up to 40% patient. 33% may require rescue PTCA because some may be different reasons. In hospital mortality, in successful rescue PCI is less than 10%, while in the failed rescue PCI, it is more than 40%. So those who have clinical problem like worsening or persistent symptoms, hemodynamical instability, electrical instability, or we show the viability, we should proceed for immediate rescue plasty. Otherwise, it is again a class 3 indication we should not do. Thank you.